So this morning, then I want to talk about nutrition and TB, which is my current major area of interest. So I want to talk about malnutrition matters because I'm going to talk about both under and over nutrition and the impacts it has on TB and how we need to consider nutrition if we want to try and meet the end TB goals. Can't see that. Oh, can we turn this light off? Which? That? Ah, there you go, that's better. Okay. So, TB is a classic example of how you have this cycle of nutrition and infection. And TB, and also to some extent HIV, are the quite extreme examples. So active TB disease, so perhaps I should start with a very brief summary about TB in case anyone's not familiar. But so TB, tuberculosis, is caused by a mycobacterial infection, and it's estimated that around a third to a quarter of the world's population are infected with TB, but most people don't develop active disease. And we still don't actually understand why that is really in any real depth. But we know that malnutrition plays an important role in that, and how competent your immune system is. So many people will be infected with the mycobacteria, and some people will control it immediately and not have actual infection, so they will eliminate it. But many people will control it, but they will have infection. And then what happens, and Japan is a classic example, is that during a sort of healthy, normal life, you just sit and you control your TB infection. And we call this latent TB infection. So there are mycobacteria present, but they are kind of asleep. They're latent, and the immune system is holding them there. But as people age, as is happening with the aging population in Japan, then the immune system starts to fail, and then active TB can develop. So in Japan, most TB cases are in the elderly. So often it's occurring in 80, 90-year-olds whose immune system is really starting to fail. So we know that the immune system is really important in controlling that infection, both the first stage and holding it in that latent stage. And we know that when you're malnourished, your immune system is not as effective, and it's particularly those parts that control that kind of immunity that seem to be affected by malnutrition. So we've known for 1,000 at least years about the relationship between nutrition and TB. So one of the reasons why also the relationship is so strong is that active TB disease, like HIV, like cancer, can produce this cachexia process, which changes your metabolism towards catabolism, so breakdown. So rather than directing nutrients to building or rebuilding muscle, etc., everything starts to break down, and particularly protein. So you start to lose muscle because you're breaking down muscle, often to release essential amino acids that are limiting, so those sulfur-containing amino acids. But also it's a process that's somewhat out of control. It's not always helpful. So you have this cachexic effect, which is also associated with reduced appetite and also increased nutritional requirements. And we can also call this process an anabolic block, i.e. you can put nutrients in, but they're not used efficiently because your system is kind of set to catabolism, which is breaking things down rather than building it up. So this all contributes to the malnutrition that we often see in TB patients. And of course, that impacts on your cellular immunity, which is the kind of immunity that's particularly important for controlling TB. And that will increase your risk of developing the active form of TB. And so in low and middle income countries, but even in high income countries, there can be a high prevalence of malnutrition in TB patients. And you can see from observational studies that that's associated with an increased risk of mortality and poor treatment outcomes. So we looked at this yesterday. So as I said, we've known for some time that it's not just the sort of medical side of things that are important in controlling infectious disease in populations. And then there was, in the UK, there was this sort of social experiment that was done in the early 1900s called the Papworth Experiment. So this was done by a wealthy entrepreneur who, he was a Quaker. So Quakerism is a form of Protestant religion in Europe and the UK, where they had very much of a social conscience, and was felt that businesses had a duty to improve the populations and the workers and education and this sort of thing. And so he did this whole village-wide population intervention where they created a sort of model village with improved housing, education, provision of free milk, everything that was known about how to improve standards of living was done, basically. And they looked at TB. And so this was reported at the time, and then this, my colleague Anurag Bhagava, who does lots of work on TB in India, he reanalyzed the original data to look at it from a sort of modern perspective. And his conclusion was that, similar to what they saw, is that it didn't seem to reduce the TB transmission from the adults that were already infected and onward to other adults, but it did reduce the incidence of TB in the children that were living with the parents with active TB. And that's because over the duration of this study, it's possible that they didn't have the power to see the effect within the adult population who'd already had lifelong exposure, etc. And they didn't look for long enough, but you can see it in the children. So these results are relevant today for the prevention of TB in children, particularly where you've got multi-drug resistant, and we have to start worrying that we could actually run out of drugs to treat TB. So drug resistance in TB is a major global concern. And yet, from this shows the power of the kind of social medicine interventions, that we shouldn't forget that drugs are only part of the story. So what are the risk factors for TB, for developing active TB? So one way of looking at this is to calculate your population attributable fraction. So what that does is it takes what we think are the best estimates of the size of the effect of the exposure. So here is your relative risk for developing active TB. So for example, if you're HIV positive, particularly if you're not on a good, effective ART program, it's 21 times more likely to develop active TB. Undernutrition, and that includes a BMI of less than 18.5. So currently there's no good estimates for lower BMI and moderate and severe. All we have is this estimate for anything less than 18.5. And most of that data, I should point out, is in the milder end, because the best data is from higher income countries. So the current estimates that are used are around 3, but it's possible that they're actually quite a lot higher for more severe malnutrition. And then another risk factor which you may not be aware of is diabetes. So diabetes also increases the risk of TB. We'll talk a little bit more about why that might be. And then we've got alcohol misuse, smoking, and interestingly, the effect of smoking is quite a lot smaller than undernutrition and diabetes. Indoor air pollution is another one. But to get our population attributable fraction, you have to take the size of the effect with how prevalent it is in the population to see the impact on your total population. So in the 30 high TB burden countries, HIV prevalence is estimated around 1.5%. Probably, 0.9%, whereas undernutrition is estimated to be 12%, which again, on a whole population level. Diabetes, 8.5%, alcohol, 4%, smoking, 19%. So obviously that one is more common, but it has a smaller risk factor. And indoor air pollution, very common. But when we look at the actual population attributable fraction, undernutrition is the biggest. And yet undernutrition is the one that nobody talks about very often, partly because it's quite difficult to tackle on a population basis, but it needs to be. And you'll see that diabetes and smoking come next in these 30 high burden TB countries. And this includes countries that are quite different from one another. So this will vary depending on each country. Yeah, in the high burden countries, because that includes China, Philippines is number 2, India, the big high burden countries where HIV is not that high. So South Africa is the huge HIV TB country, but a lot of the high TB countries don't have such prevalent HIV. So that's why that's not as high as you might expect. And of course it's the whole population, including children and elderly. So as I said, these, I'm going to call them PAFs because it's easier to say, population attributable fraction. This is the case of India. And again, this is my friend Anurag, and he looked at different countries using best available, more sort of local contextual data. And if we look at the case of India, for undernutrition, it's 55%. So he estimates that 55% of active TB is due to the effect of undernutrition in the population. And you can see that varies quite a lot, but many countries are high as well. If we've got South Africa, we can see that it's lower because if we've got HIV, where are we? South Africa. You can see it's so high for South Africa. So when we're trying to meet the NTB goals, which we'll send around a summary document about the NTB goals and what they are and how they're proposed to be met. But basically, they are saying that by 2030, there's one set of goals for 2030 and one set for 2035. So it's a bit confusing, but basically they're saying we should reduce the incidence of TB by 90%, which is a very tall order. And at the moment, we're not on target to meet those goals. So the incidence of TB is decreasing, but not fast enough. We need that rate of decrease to nearly double to meet that goal. And currently there's no sign of the rate increasing, or the rate of decrease increasing. So there's been some nice modelling studies that have taken the effect of the changing different risk factors on a sort of global or a country level. And this one was nice because it looked at the effects of nutritional status and diabetes and undernutrition. And of course it gets a bit complicated because as populations' nutritional status shifts, if on a population basis, if it's moving to the right and more people are becoming overweight, then you increase your risk of diabetes, that increases risk of TB, but you reduce undernutrition, which also increases. So there could be a balance. So ideally, we want to shift everyone into the normal range of BMI, but that's not what's happening. What's happening is that it's all shifting to the right, and you're pushing people into the overweight. And this is particularly happening also in Africa, but more rapidly in some of the South and Southeast Asian and WIPRO countries like the Philippines, where I'm working. Plus, you have inequality. So again, places like the Philippines, also India, you're beginning potentially that normal distribution of BMI is becoming slightly less normal, in that because of inequality for BMI, you have a population of undernourished and a population that are getting too fat, and then the middle. So on a very sort of global scale, it's all sort of shifting to the right, but in a lot of places with inequality, you're remaining with those populations with malnutrition, whilst also having a population who are putting on weight too much. So what they did in this modelling study was they looked at different scenarios and said, okay, let's say that in scenario 1, that diabetes continues to increase in prevalence on its current trajectory, and there's no change in undernutrition. And then what do you see in terms of the change in incidence of TB? It's going to increase if we do nothing. So this is assuming no sort of interventions. Undernutrition remains the same, diabetes increases. Scenario 2, it's kind of the worst case scenario, increase in diabetes and increase in undernutrition, and we go up 10%. So we're aiming for a 90% reduction, and these are our worst case scenarios, that it goes up. Whereas scenario 6 is where the effect of diabetes is mitigated, which would mean by effective, rapid diagnosis and management of diabetes, and that we eradicated undernutrition. Well, we've been talking about eradicating hunger and undernutrition for the last 50 years, and we haven't managed it. We are getting better. Before I sound too doom and gloom, when you look at the global figures in terms of proportion, it is going down. So we are making progress, but the population is getting bigger and bigger. So the absolute numbers are not changing that much, but as a proportion, we are making progress. So I don't want you to think that everything's awful and malnutrition is getting worse, because it's not. But it's still a major problem. So this was a really nice modelling study, but it's still very simplistic, because what they're doing is they're making a standard assumption using a risk ratio of 3 roughly for diabetes and 3 for undernutrition. So that's assuming the effect of a BMI of 16 is the same as a BMI of 18.2, which it probably isn't. And it's also not taking into account the effects on ongoing transmission and failure. So we know that if you're diabetic, not only are you more likely to develop active TB, but your treatment is less likely to be effective, or that it will take longer for your treatment to make you non-infectious. So to make a more complicated model, you need to think about, okay, how many more extra cases could this person transmit if they're infectious for 1 extra month? Or we know that diabetes can change the presentation of TB, so you're less likely to get diagnosed as having active TB if you're diabetic. And that's because things like the cough reflex can be suppressed, so you don't present with such obvious symptoms, but at the same time you're still infectious. So there's a whole load of other things that you could try and include in this modelling, but it gets rather complicated, and we don't have good data to put numbers to it. You know, it would be guesswork, best guess. But these are some of the ways in which these transmission might increase. Again, reduce drug adherence through side effects. So if you're acutely malnourished, there's not currently very good evidence yet, but sort of it makes sense, and there is observational evidence suggesting that you have more side effects. And the side effects can be really severe, so that people stop taking the drugs. Especially is if you take the drugs for a month and you're getting the right drugs for the susceptibility of your TB, you start to feel a whole lot better. You stop coughing, and then you think, oh, I'm fine. And then, so if you're having drug side effects at the same time, but yet you're starting to feel better, you're much more likely to stop taking them. Reduced drug efficacy is a means why, if you're malnourished or diabetic, maybe the treatment success is not as good, and there are reasons why we might think that they also might be more infectious, not just for longer, but actually more infectious than somebody who's not diabetic or not malnourished. Okay, I think that's we've summarized the main ones. So as I said, malnutrition or wasting, so a low BMI, because I'm talking about adults at the moment. The same is true in children, but there's less data. So I'm going to concentrate on adults. So even in high-income countries, malnutrition occurs in TB patients and is associated with an increased risk of death. So here you've got a risk ratio of 4 for risk of death in a study in Japan. This is using a sort of clinical malnutrition risk score, which is often used by dietitians. And see, this is on BMI. But then this is from one of the largest, best studies so far in India, and where it is extreme. So India has one of the highest prevalences of adult undernutrition of anywhere. And then this is so at the start of treatment, 55% of patients had a BMI of less than 16. So that's severe thinness, severe acute malnutrition. And then he looked at the adjusted odds ratio for risk of death. So for every unit increase in BMI, the increase was 22. So your odds of dying decreased by 22%, roughly, for every increase in BMI. So as your BMI goes up, your odds of dying decrease. So then we have to think, okay, so we know that malnutrition is important in TB. What's the evidence? What do we do about it? So the most recent Cochrane review for nutritional supplements for people being treated for active TB only contains 6 trials of macronutrients, of protein energy. There are more trials of micronutrients, but still not very many. So Cochrane, I hope you're all familiar with Cochrane reviews. So these are reviews of clinical trials, randomized clinical trials that meet certain standards of quality of evidence. And clinical trials should provide you with the best available evidence for whether something actually works or not. So after all this time, and I'll show you an update of this, there's been a slightly new update, but there's basically no new trials. 6 macronutrient trials, but look at the size. The Tanzanian study, which was done by my colleague at the London School, is really the only one that is remotely powered to look at anything useful or important. These are, just hugely. They're not powered to tell you anything. So really, the trials of interest are this one in Tanzania and this one in Timor-Leste. India, again, not really powered. And then what are the outcomes? Then only one study had an outcome of death, and that was the one in India that was not powered to see an effect on death. Only one study to look at sputum culture, which was Mexico, which is far too small. Treatment completion, so at least that's the kind of useful outcome, but again, I think they wrote that it was powered, but it probably wasn't. And then the studies in Tanzania was powered to look at change in nutritional status and body weight. So if you think that this study included 865 people, and that was adequately powered to see just an effect on nutritional status, it kind of gives you an idea of the kind of numbers that you would need to really be powered to look at mortality. Because in most effective TB programs, your mortality shouldn't be that high. So if your outcome event is relatively rare, you need more people to see an effect. So this is just a bit more detail about the kind of summary of the level of evidence and the outcomes that were assessed. So this is food provision compared with nutritional advice or no intervention for patients with active TB. So again, you've got different sort of placebo arms, because one is some studies are nothing and some studies are nutritional advice. So in effect, that's not nothing, because that's more than what normally happens in most real TB programs. So as you can see, you've got death, and then here was your risk ratio for these studies, but again, you can see the confidence interval goes from 0.07 to 2.25, so non-significant effect. You can't make any conclusions. And so this is the kind of summary quality of evidence, and you can see basically it concludes very low, very low, very low. But it's important to remember that this very low quality of evidence doesn't mean that it doesn't work. It means that we don't know, because no studies have been ably designed to assess it. So here he says we don't know if food supplementation reduces mortality. We don't know if food supplementation increases cure. We don't know if food supplementation increases treatment completion. We don't know if food supplementation reduces the duration of sputum positivity. So how long it takes for a sputum culture to be negative, which is indicative of how long the person might be infectious for. So then this is a slight update, WHO. So there is this guideline document, But really, it's very unclear. And most programs have no idea and no capacity to implement any of the recommendations as to how would they operationalize any of these things. So for children, it is relatively clear. It says conditional recommendation to treat moderate malnutrition in TB adults and children more than 5 years of age, and it recognises a low quality of evidence. But it doesn't say how to treat them. And a strong recommendation to treat moderate malnutrition in TB pregnant women or multi-drug resistant TB. But then it says very low quality of evidence. So they're making a strong recommendation based on an almost absence of evidence, which, you know, in a way they kind of have to, but then why isn't there a big push to generate this evidence? And then this is basically an update of the table you saw before, but there's really pretty much no change. So there are, what I haven't written here is there are recommendations for treating severe malnutrition for children and adults. And for children, it might be a bit more obvious because we have strong recommendations and policies as to how to treat severe malnutrition in children under 5, and it basically says just do the same thing, which I agree with, that makes sense to me. But for older children and adults, very few countries have programs or policies, and nothing is in place. So again, how do you diagnose malnutrition in a practical way in older children? People are not used to trying to do a BMI for age Z-score. There's not the knowledge and awareness and access to suitable nutrient interventions. What's time? So now I want to talk a little bit about some of the studies that we're doing in the Philippines. So first, we're going to look at an inpatient study that is finished and a cross-sectional study that we just finished last year. And these are really just trying to generate the basic data for us to give us a firm grounding of designing the future studies. So Nagasaki University's been working in this San Lazaro hospital in Manila, the Philippines, for some time. And this is a tertiary referral infectious disease hospital, which has a very large TB ward. And the hospital serves very poor populations in sort of slum areas of Manila. So it often gets pretty much the poorest of the poor patients in Manila, particularly for TB. And the mortality on the ward is extremely high. So we tried to recruit adults who admitted to the TB ward with known or suspected TB. So you're only admitted really if you are known to have TB or it's thought that you have TB. And we looked at mortality by clinical wasting, and we used a cutoff of 17.5 BMI, which I now think is wrong, but that's what we said at the time. Saying that I think it's right, but it's not what everyone else normally does. So we'll probably change it. But if you look at our data, it actually looks right. So because it's a clinical setting rather than a community setting, that's one reason why we use this 17.5 rather than 17. So there's the sort of outside, the ward is that side, and there's the TB office, and then there's the TB dots outpatient to the right over there. It's a picture of the ward. The wards are actually either side of this corridor. And this picture is actually rather misleading because normally, or at least more than half of the time, down the middle of that corridor will be beds, camp beds. And the ward is designed for, I think it's 40 patients. There's been over 100 sometimes. So it's a very busy ward. It has over 1,500 admissions a year. But compared to what I was used to seeing in even the National Hospital in Dar es Salaam in Tanzania, it looks great. There are beds, proper beds. Everybody's on drips. It's pretty clean. So at first I was like, wow, this is amazing. There's a reasonable number of staff, not enough, but there are quite a few nurses on duty every day. But here are some of our TB patients. So these are our field staff or research nurses collecting data from our admissions. And you see this guy here, and you can see the level of wasting. And this is by no means our most severe patient. We had people admitted to the ward with a BMI of less than 10. A BMI of 10 is supposedly incompatible with life. So it's a waste of time putting expensive TB drugs in somebody with such a low BMI unless you're going to do something about the malnutrition as well, and pretty quickly, because they're going to die of malnutrition. So as well as looking at the risk of mortality on the ward, we wanted to get more contextual information. So we wanted to look at, well, how much were patients, what was their intake during admission, how much was being provided by the hospital, was it an adequate diet, how much were they receiving from their own pockets and from relatives bringing in food. You're not allowed to be admitted to this ward unless you have what they call a watcher. So somebody has to be with you when you're admitted, and there's supposed to be somebody with you to help look after you, because there's not enough nursing staff to fully look after every patient. We wanted to look at the diagnosis and treatment of malnutrition routinely. Was it being recognised? Were any interventions being given? In theory, the hospital has the capacity to do nasogastric feeding and even other kinds of feeding, but it's not being done. They even have dietitians, but the dietitians never leave the hospital kitchen. The only things they ever do is work on planning the menu, which is just the same for every adult patient in the hospital. And then we wanted to look at weight change during admission and look at body composition. And we wanted to look at grip strength. So grip strength is a functional measure of body composition, because rather than just your fat mass or your muscle mass, how effective is that muscle? And in some other studies, it's shown to be more predictive of outcome. We were looking at diabetes as well. We wanted to look at how well TB was being diagnosed on the ward, and we did in our own sort of study algorithm. And there's a gene expert based test, which is sort of, in simple terms, a more sensitive lab-based test than the standard. So we did this on all patients. And we also wanted to try and look at post-discharge outcomes. And we planned subset analysis. I'm not going to present results for most of these because it would take ages and the data's quite complicated and we're still analysing it. But here's just a summary of what we did. So during admission, we collected all this information: height, weight, grip strength, body composition. We did skin folds as another means of trying to tell you the fat percentage, symptom screen, and then we looked at, again, the diagnosis and some lab outcomes, and also HIV testing. So again, it's policy, it's national policy in the Philippines and most places that all TB patients should be HIV tested. It's not happening at all. HIV in the Philippines is very low compared to lots of places, but it's now the most rapidly increasing HIV incidence in the world. And the government is being very, very slow to do something about it. And trying to get HIV testing done was incredibly difficult. So we were still forced to go through the whole extra consent and voluntary care and testing, rather than it being, this is just part of your routine TB care. So many patients refused, and we had to implement it ourselves. So we had to train our own staff, because there were no staff available that were trained in doing the pre and post-test counselling. The rapid tests were only sometimes available, sort of thing. So here we are taking some anthropometry of our patients. So the problem is that with BMI, which is what you'd want to measure, but of course some of these patients are really sick, and so they can't actually stand up to do a height. So we tried doing limb length, so a demi-span from here, and also knee to ankle, which we are looking at modelling to see how well it predicts height in this population, and whether we could then calculate BMIs using the predicted height. But probably more useful is to do MUACs, so mid-upper arm circumference. But the problem is there are no set cutoffs for adults. So we're again doing our own modelling to see what MUAC cutoff might predict either mortality or correlates with BMI. And then we did the skin folds, and we also did the bioelectrical impedance for body composition. I think we have, so here's the machine that does this. So what it does is that it passes a very small electrical current up through the feet, and then through the body, and then out, so they have to hold the hand grips so that the current goes through. And there is how much current passes through depends on the amount of fat, because fat and water don't mix, and water conducts electricity. So the more fat you have, the less electricity passes through, or the more resistance there is. The problem is with this, which we hadn't really thought about so much, was that all the patients are on drips. So their hydration status, which makes a big difference, and their drips were not well controlled. So, the patients are all different kinds of hydration status. And our results, we've almost decided to just junk them, because we've decided they're uninterpretable, unfortunately. So this is the summary of our results. So one of the problems was, as I said, there's 1,500 admissions to the ward, but we only managed to recruit 360 patients. And this is partly because we weren't recruiting at weekends, and then also we were unable to recruit the sickest patients. And this was not always because they were so sick that they couldn't consent, but also families were refusing, especially in the sicker patients. So then this is our prevalence of BMI. So less than 17.5, 44.3%, more than similar percentage, but we weren't able to get BMI in everybody. So if I go straight onto the primary outcome, so what we saw was that these are the proportion of patients that died within 1 month. So they survived the first 2 days of admission and then died within 1 month, which was our primary objective. And we had 13% versus 9.4%. But our initial sample size was based on previous data on a much higher mortality. And it's probably because we weren't recruiting those sickest of patients, and look at the mortality in those that we weren't able to measure the BMI. So these are the sickest patients, who probably had much lower BMI and much higher mortality. So this is why we did MUAC, and we're continuing, and we're going to increase recruitment. So we're going to restart recruitment, and we're going to look at how MUAC predicts mortality risk, because it's just not practical to get enough BMI measurements, and we're missing the patients, the sickest patients. Just quickly, so we assessed diabetes actively, so everybody was tested for diabetes with HbA1c, and the prevalence of everyone was 15%, which is, if you think that the prevalence of diabetes, official figures for Philippines is 4.5%, which is probably an underestimate. It's probably more like 6 or 7%, but much higher in the TB patients, because diabetics are perhaps more likely to develop active TB. But most of those patients had not been previously diagnosed. Right. So I think I've answered that already. And then, so this was the next study that we did, which is in outpatients. So that inpatient population are acutely unwell, and often the poorest of patients. Often they've probably had TB for quite a long time before getting so sick that they're admitted, so they haven't sought healthcare because they don't have any insurance, and they're from the poorest sort of groups. Whereas the outpatient population is going to be a little bit different. So primary objective was very similar. Look at the prevalence of wasting. This time we use BMI of 17, so which is moderate acute malnutrition, and diabetes. And we looked this was a multi-site study, so we were looking in Metro Manila and in sort of more rural sites in the Western Visayas. So we aimed to recruit 600, and we managed to recruit 637, which was pretty much everyone enrolled in these TB DOTS clinics. So these ones are Metro Manila, and these ones are in Western Visayas, so more rural. I'll skip that for a minute. So here are our main results. So prevalence of BMI of less than 17, so moderate or worse malnutrition. In Manila, 16.7%. In Negros, 25%. And that difference was statistically significant. And then we looked at diabetes, and interestingly, it was lower in Manila than in more rural Negros, which is the opposite of what we expected. But Negros is a sugar farming area, so it could be to do with that. It could also be that in Manila, patients who are diabetic, they do tend to be slightly more overweight and better off, and that they weren't attending the public facilities. They may have been going to private, so that might be why we see this difference. And when we looked at the diabetes, this data is just for Metro Manila, but many patients were previously undiagnosed, so they had no idea that they were diabetic. And some of these patients had extremely high HbA1c, which is the marker of amount and duration of glucose dysregulation. And it's those diabetic patients who are the most at risk. So we know that managing diabetes and controlling blood glucose levels helps to reduce the impact on TB. So what things were associated with being malnourished? So it was a significant difference by sex. And by treatment phase, which is probably what we'd expect, so at the start of treatment, you're in this intensive phase, and by the time you start continuation, you should start to be recovering and feeling much better. So there is more malnutrition in the intensive phase. And also poor appetite was more common in wasted patients. We looked at the relationships between MUAC and BMI and grip strength. And MUAC does correlate fairly well with BMI, and so we are in the process of developing potential cutoffs for predicting BMI, but we probably need more data points. Diabetes management, as I said, only about half have been previously diagnosed, and those that were, quite a few were on treatment and on metformin, and metformin is available and free, especially for poor patients, through either the PhilHealth, which is the national insurance, or through these special programs where you don't even have to be enrolled in PhilHealth. But the problem is that diabetes diagnosis is not free. So metformin is provided to health clinics, but there's no money provided to clinics or paid to patients for diagnosis or for monitoring. We also looked at anemia, because anemia is one of the symptoms of TB. And we found that, as expected, it decreases during treatment, so that by the end, anemia is less common, but it was still 23% in the last month of treatment, when in that last month, you should be kind of back to where you were before you had TB. And the national prevalence of anemia is 9% in adults. So you've got patients who are finishing treatment who are still anemic. The table I didn't find to put in here was also nutritional status by duration of treatment. And also what we saw was that, again, wasting decreases, but still the prevalence of wasting at the end of treatment was still double what you would expect in the normal population. So you've got patients who are finishing treatment, who are still malnourished, and you're sending them back into an environment where they got TB the first time, and now they've still got an increased risk because they're malnourished. So this is why my argument is that you're not fully treating the patient if you're leaving them malnourished and anemic at the end, because they're at increased risk of just reacquiring TB or the TB coming back. We also looked at patient costs. And what's the time? Because I've got my watch. 11:30. Okay, it's not too bad. We looked at total patient costs, because this is also one of the NTB goals, which is to eliminate what they call catastrophic costs of patients in TB care by 2020, so very soon. So all TB drugs are provided free in just about all countries, low and middle income countries, with massive support from the Global Fund. But there are still costs associated with treatment. So if you're enrolled in TB DOTS, which is direct observation, in theory originally, you're supposed to go every day to the clinic and be seen to take your drugs. It's not happening like that in most places because it's just not practical. There's not the staff and people just can't do it. But they're supposed to go either weekly or fortnightly to collect drugs and to be seen to take them. And at a minimum, they have to go and give sputum samples back at 1 month, 2 months, and in theory, 5 months. So there's travel costs, there's time costs. The costs of diagnosis is still not always covered. So to seek treatment in the first place, to seek a diagnosis, is not free. And then the other thing is the time costs and the potential earning loss. If you think a lot of these people are poor, they're either farmers or they might be petty traders. So they're standing by the side of the road selling small things or selling food. All the time that they're not there, they're not earning money. So it's costing them to go to the clinic. So there's a WHO catastrophic cost sort of questionnaire that's paper-based that had been translated to Filipino languages already. And we put it onto ODK, which is a platform, tablet-based platform. And we added further questions about diabetes and malnutrition. Again, because one of the stated policies for reaching the end goals is that diabetes and TB should be managed together. But again, that's not really happening. It would require a lot of infrastructure change to place diabetes managers and staff into TB clinics. So at the moment, in theory, it's policy or recommended that TB patients are tested for diabetes and are managed, their diabetes is managed through the TB program, because you don't really want your TB patients going to a diabetic clinic and sitting in that diabetes clinic with all the other diabetic patients who are at increased risk of contracting active TB. So you want to keep them separate. So we added those extra questions to see, well, they now have to go to the TB clinic, pick up their drugs, and then they have to go to the diabetes clinic or somewhere else to get their diabetes drug or be measured. They then might have extra requirements for dietary, what things they're supposed to eat, etc. So this was just pilot data, but again, and we looked at how the proportion of household income by their income before TB, and of course, the poorer you are, the bigger proportion the TB is taking up of your costs. So in the poorest people, nearly 25% of their total household income was going towards the costs of their TB managed diagnosis and management, even though all the drugs are free. And then what we saw was that a lot of those costs are from the pre-treatment, so the diagnosis costs, travel costs, and the indirect, so income loss costs. But also, like the national prevalence study, we also found that patients were spending money on foods, special foods, and that was a major contributor. So patients are buying these sort of supplements that may or may not be working because they're mostly bought from small private vendors and are supplements with no proven efficacy. So they might be herbal things, etc., vitamins, herbal, but we should be providing them with things that we know are efficacious, not letting them spend money on things that possibly don't work or could even be dangerous. So here we were looking at, again, the effects or sort of costs, extra costs, if you like, of having malnutrition and diabetes as a TB patient on quality of life. So this is using a standard WHO score, and you can see that for some of the measures, there are significant effects of malnutrition, as you would expect, physical, but also psychological, and diabetes also on physical and psychological for anemia. HIV, just to emphasize that we weren't able to test an awful lot of patients because of refusals. And San Lazaro is very high because it's the HIV reference referral hospital. So that's not a normal result, as you can see from the other clinics. So other studies, This study was supposed to start in January. It still hasn't started, but it will do very soon, I hope. So that cross-sectional study was really done to allow us to power and to give us an idea of how best to do a longitudinal observational cohort. So we were able to do a proper sample size based on good data on the prevalence of malnutrition and diabetes and an idea of urban-rural differences. And so we're now looking at enrolling patients from the start of treatment and following them up to the end of treatment, and also, if we get a bit more money, post-treatment. So again, there's this idea that I want to see the effects of finishing treatment still with malnutrition or anemia on what happens to the diabetes patients. Because increasingly there is management occurring because they're a TB patient, but then once they finish treatment, the diabetes often gets dropped and forgotten about. So we want to look at recurrence in these patients as well. And then we've got another study which we'll find out whether we've got the money for in maybe about 2 weeks' time. So this is a large study where, and this number's not correct actually, we're going to screen 5,300 household contacts and for diabetes and also malnutrition. And we're going to look at the risk of latent TB infection in these household contacts. And then we're going to follow them all, everyone up for 2 years to look at the risk of developing active TB. Because we need to start thinking about treating people with latent TB with a high risk of developing active TB if we want to meet our NTB goals. Just waiting to see active patients coming to clinic is not enough. And so we want to show whether diabetic household contacts might be at increased risk of developing active TB, that you could treat, you could do prophylactic treatment of the latent TB. So we're going to include cost effectiveness modelling of this. And this will be the first data, almost the first data that will look at this issue. So all of this is designed, we hope, to lead to adequately powered clinical trials of interventions. So again, we need to know the context to know what kind of interventions might work. And we need to understand how the local health systems are working, which we only see once we really get embedded and see what the issues and problems are. So these are some of the people that have helped with all this research. Particularly, I collaborate with Nutrition Center Philippines. Juan Solon, we know each other from when we were both working in the Gambia. So it's very nice that we've come back together to collaborate now. And then, yes, everyone at SLH. And there's my assistant professor who's now gone on to greater things. And then these are the staff that were working on the inpatient study. Okay. So, thank you very much, everybody.